Hi, I'm Martha Blaess, a PhD candidate here in the Department of Nutritional Sciences in the College of Allied Health. I'm also a speech-language pathologist and have been practicing for the last 5 years here in Oklahoma. I'm currently practicing at a pediatric outpatient clinic where I'm the director of our feeding program. And most of my caseload consists of children who have autism who are also receiving services for selective eating. Today I'm presenting to you my doctoral dissertation research, and it's entitled RDN and SLP Collaboration, Treatment Knowledge and Intervention Approaches for Selective Eating and Autism, and it's a mixed method study. Here is my committee made up of 5 committee members. My co-chairs are Dr. Katie Eliot and Dr. Alan Knehans. The rest of the committee is Dr. Lee Hoffman-Anderson, Dr. Bonnie McBride, and Dr. Mark Fisher. This study is funded by the College of Allied Health Student Research and Creativity Grant, as well as the Children's Hospital Foundation of Oklahoma, specifically the Oklahoma Autism Center. So let's start talking about autism and selective eating. So children, or in the United States, 1 in 44 children are diagnosed with autism. Now, up to 89% of those children are considered to be selective eaters. So what is a selective eater? A selective eater is somebody who is refusing food, who has a limited food repertoire, so who has a limited amount of foods in their diet that they're willing to eat on a consistent basis, as well as a high frequency of a single food, so high intake of a single food, meaning they're only eating Pringles basically at every single meal. Now, this selective eating falls under the diagnostic code of pediatric feeding disorder, or PFD. You may hear parents or other people refer to selective eating as somebody being a picky eater or picky eating, a problem feeder, a problem eater. All of those really relate back to selective eating. Now, why should we care about selective eating? From the lens of dietetics, selective eating can lead to a lot of nutritional deficiencies that end up leading to type 2 diabetes, hypertension, dyslipidemia, all sorts of chronic diseases. And then from the lens of speech pathology, selective eating just creates an immature diet in a child. So a child who's 8 may only be eating pureed foods. This can also lead to a lot of family stress when a child will only eat Pringles, and so a family can't go to Chick-fil-A, or a family can't go to Sunday dinner with the rest of their family. So a lot of family stress comes from selective eating. In order to treat selective eating, there are a variety of different strategies, and they're kind of all over the place and have a different amount of evidence towards each. So these 4 strategies, really the 4 main categories of treatment strategies for selective eating, would be behavioral strategies, nutritional strategies, oral sensory motor strategies, and mixed strategies. On the right, here's some pictures that are showing you what these strategies look like. So the top left picture, this child often uses behavioral strategies. So working on the skills to eat, so trying to have a rotary chew or tongue lateralization. We may practice that 5 times and then get 5 stars, and then we can read our favorite book, Brown Bear, Brown Bear. The child on the right uses a mixture of strategies and therapy. This specific picture, we're using more nutritional strategies where we're in a grocery store playing My Plate Bingo to try to get some nutritional components into his feeding therapy. Child on the bottom picture is a child who uses a lot of oral sensory motor strategies. So he has a lot of difficulty being in the same room as these non-preferred foods, but he loves numbers and he loves clocks. And so often we'll try to go from a sensory strategy and interacting with food at a safe level. Now, literature also shows that really the most evidence-based treatment strategy would be a behavioral strategy. Now, here's where the collaboration piece comes in. We know that the definition of collaboration refers to healthcare professionals assuming complementary roles and cooperatively working together and sharing responsibility for problem solving and making decisions to formulate and carry out plans for patient care. So this is really seen in dietitians and speech pathologists who collaborate in the treatment of dysphagia. Their roles are really intertwined. For the role of a dietitian, they are going to provide the SLP with food guidelines and recommendations to improve nutritional quality of the patient's oral diet. Whereas the SLP will educate the RDN on consistencies of foods that are required for a safe swallow, as well as to promote oral motor abilities and to involve the patient's food aversions and preferences. So the SLP can help the RDN know those. But what's missing? Well, there's a part missing in the treatment of pediatric feeding disorder. There's abundant literature out there that shows that an interprofessional team in their treatment of pediatric feeding disorder is really advantageous for a child and their outcomes. But what's missing is the role specifically related to a dietitian and an SLP and how they complement each other to manage pediatric feeding disorder. So we know that RDNs and SLPs enhance one another, their roles are intertwined, and so this holds promise to improve dietary outcomes of children with autism. There were two purposes to the study, the first one being that the purpose was to measure and explore knowledge of dietitians and speech pathologists and their use of evidence-based intervention strategies. The second purpose was to explore the impact of their collaboration on their knowledge and use of evidence-based intervention strategies. There were three aims: measure and explore knowledge, measure and explore the use of evidence-based intervention approaches, and then explore the impact of RDN and SLP collaboration and the impact on that knowledge and their use of intervention approaches. This study design followed an explanatory sequential mixed method study. So phase 1 consisted of quantitative methods, and that was through a survey done on REDCap. Phase 2 was qualitative. Emphasis was put on the qualitative methods, and those were semi-structured individual interviews. Here was the recruitment graphic that was posted in a lot of different areas to recruit participants. For phase 1 results, 111 dietitians responded to the survey, 137 SLPs responded to the survey, and then 0 duly credentialed SLPs and RDNs responded to the survey. Phase 2, 10 dietitians were interviewed, and as well as 10 SLPs were interviewed. So aim 1, as a refresher, it was measuring and exploring dietitian and SLP knowledge in their treatment of selective eating. So we found that over 50% of RDNs and SLPs reported comprehensive and even extensive knowledge related to treatment of selective eating. Aim 2 was looking at their use of evidence-based intervention approaches. And so here was a list on the survey that clinicians could mark what intervention approaches they used. So the top 3, the most frequent intervention approaches reported, were systematic desensitization, food chaining, and then parent and caregiver education, all of which lack a really behavioral strategy approach. And then finally, aim 3 was the qualitative phase. And this was exploring the impact of RDN and SLP collaboration on knowledge and intervention approaches. And so because data collection actually just ended, haven't fully analyzed all of the transcripts, and so we have a preliminary code book right now. We've identified several themes, and the themes that are pertinent to today's discussion are the provider roles of SLPs and RDNs, and then the impact of feeding team collaboration on provider knowledge, provider treatment, and then patient outcomes. So here are some just interesting quotes that we gathered from the first 4 transcripts that we've analyzed so far related to those themes that we just discussed. So talking about SLP roles, RDN roles, and SLP sees their role as mealtime support and patient safety to educate the caretaker. RDNs talk about their role for caretaker education and prioritizing goals related to a patient's health. And then the impact of collaboration between RDNs and SLPs, we see that it impacts provider knowledge, so it helps them expand their thinking, and it also helps them to treat patients holistically, and that you need multiple people contributing to a patient's case. So in discussion, we see that RDNs and SLPs report comprehensive knowledge related to their treatment selective eating. We also see that RDNs and SLPs rely on a non-evidence-based intervention approach. So really they're using more oral, motor, sensory, nutritional approaches rather than behavioral. And then we also see that collaboration between RDNs and SLPs is highly valued by clinicians, and it benefits the patient, the family, and the providers. So what are the implications for interprofessional education and collaboration? Well, we see that collaboration between RDNs and SLPs increases provider knowledge and allows for holistic treatment of patients. We also see in some of our preliminary transcripts that we've looked over that RDNs and SLPs who are unable to collaborate see gaps in their practice and patient outcomes without the counterpart, so without the RDN or the SLP. And then RDNs and SLPs have learned about the other's role on their job. And so those who have access to RDN and SLPs report more holistic care. So all of this shows us that interprofessional education and collaboration among healthcare professionals promotes understanding of each other's role, value of each other's profession, and then reliance on each other's skills to promote those patient outcomes. I do have references that I'm happy to share with you if you would like. And I look forward to our discussion.